Hello, Namaste. Today we'll discuss about complications of CSOM. To start with, complications on CSOM occur when infection spreads beyond the muco-periosteal lining of the middle cleft. Either it involves the bone or into neighboring structures like facial nerve, inner ear, dural venous sinuses, meninges, brain tissue, and soft tissues. Multiple complications are not uncommon, and they occur in around one-third of the patients. And children are more commonly affected than adults because they have well-pneumatized mastoids. Let's go to factors affecting complications. They are pathogen factors like high virulence of the bacteria, antimicrobial resistance, patient factors like young children, as already told, they have pneumatized mastoids, poor immune system, concurrent chronic diseases, and poor socioeconomic status all lead to decreased immune power. So there might be complications, and lack of health awareness. When the patient is not aware about their health, then again this might lead to complications. Physician factors like non-availability in the remote areas, which is still common in our country, injudicious antibiotic use leading to masking effects. Suppose when the patient takes antibiotics just for 4 to 5 days and lives like that. And third is the error in recognizing danger symptoms or signs like swelling behind the ear, just suspected as abscess or furuncle, or when the patient is having severe headache, vomiting, then suspecting other conditions might lead to danger symptom failure. Let's come to etiology of acute and chronic otitis media. I think all of you know the most common causative agents in acute otitis media is Staphylococcus pyogenes, and in CSOM there are multiple agents, and the Pseudomonas aeruginosa being the commonest. What are the routes of spread of infections? They are: first is direct bone erosion, either by hyperemic decalcification in acute stages or resorption by cholesteatoma or osteitis in chronic infections. Next is thrombophlebitis, either from lateral sinus to cerebellum, that is goes through the vascular route, we'll come to it later on, or from superior petrosial sinus to temporal bone, temporal lobe. Third is from normal anatomical pathways like oval and round windows. As you know, they are the open windows, cochlear and vestibular aqueducts, dehiscence of tegment tympani, etc. And fourth is non-anatomical bony defects like accident, surgery, or neoplasm. Surgery like stapes surgery into brain tissue along the periarterial spaces of visceral vein is also one of the common cause for the complications to occur. Complications of CSOM can be classified as intratemporal complications like acute Coalescent mastoiditis, Petrositis, inflammation of Petros apex, Labyrinthitis, inflammation of labyrinth, Labyrinthine Fistula, and facial paralysis. Extratemporal are subperiosteal abscess, Citylis abscess, Bijol's abscess, Luke's abscess, zygomatic abscess, and occipital abscesses. They are basically abscess in relation to mastoid. You might be asked in the exam. Third is intra-cranial complications. They are one of the common complications of CSOM till now in the developing countries, but they are uncommon in developed countries. They are meningitis, extradural abscesses, subdural abscesses, brain abscess, lateral sinus thrombophlebitis, otitic hydrocephalus, and brain fungus. Systemic complications still are not uncommon in the underdeveloped countries. They are septicemia and otogenic tetanus, although they are very rare nowadays. Let's come to acute Coalescent mastoiditis, which is one of the commonest complication of CSOM eticanthal disease, or still complication of ASM also. It is defined as acute osteitis of the mastoid cells. So the name Mastoiditis, inflammation of mastoid ear cell system. The coalescence is defined as destruction of the walls of trabecular ear cells until they are joining together to form a single irregular mastoid cavity, which occurs in children. As already told, the mastoid is pneumatized in children, basically well pneumatized mastoids and ASM. The pathology is Otitis blockage. This is the, as you know, this is the antrum, and this is the Otitis, and this is the etic region, etic Otitis antrum. This is the pars tensa, this is the pars flaccida. So when there is a blockage of the Otitis, that leads to failure of the drainage of secretions from the mastoid cavity or mastoid to the middle ear, that leads to stages of secretions there, again leading to hyperemic decalcification. As you know, the trabeculae in children, they are weak. weak trabeculae and pneumatized mastoid all lead to destruction of the bony walls of ear cells and collisions of small ear cells to form an irregular large cavity. So this is irregular cavity which leads to complications. Symptoms of acute coalescent mastoiditis are otalgia, which is the common complication, which is in compared to ASM, otalgia persists for more than 2 weeks. There is increased intensity of pain and recurrence of pain within 3 weeks, suggests acute coalescent mastoiditis. First oral pain, fever, ear discharge, which increases on reservoir when the patient is having no obstruction, and it increases. So-called reservoir sign happens there, and it's decreased when there is itis block. Then decreased hearing, masked mastoiditis are the common things. It is defined as absence of classical symptoms due to antibiotic use. So when the antibiotics are not properly used, when they are used for some time, then patient will be having disease. But that antibiotic for some time, the masks the disease. That is called as masked mastoiditis. Again, when the patient stops taking antibiotics, and then patient will have problems. Signs are pinna is protrude forwards and downwards. Contrary to the simple furuncle, the pinna is protruded more forwards and downwards. But in case of furuncle, the pinna is simply protruded forwards only. There will be obliteration of the post-auricular groove because there is mastoiditis. There will be mastoid tenderness, and the smooth iron out feel of the mastoid can be felt when you feel the post-auricular area. There will be sagging of the posterior superior bony canal wall, which is probably due to osteitis of the floor of the mastoid antrum. The reservoir sign is seen when there is no obstruction for the itis of secretions. You can see prudent discharge which refills external canal after cleaning. TM findings are usually unreliable, so don't believe on the tympanic membrane findings, because as already told, there will be either no perforation of the tympanic membrane, there will be simple bulging, or there might be perforation of tympanic membrane and pus comes out as the lighthouse sign, or there might be simply perforation of TM only and the pus doesn't come out when there is erythus blockage. This is the pinna, which is forward and downward lying due to mastoid abscess or acute coalescent mastoiditis. And on posterior, when you examine the swelling, there will be ironed out peel when just on examination, and there will be obliteration of the retroauricular groove, which is usually there should be a groove here that is obliterated. As already told, TM findings are not much reliable, but in case of ASM, you can see the discharge coming out. But in case of ASM plus mastoiditis, sometimes there might be simply etic congestion only, so there might not be any disease or any defect found yet there. Investigations to be performed are complete blood count, total count and differential count has to be done, and total count will rise and the ESR also rises due to acute or chronic infection. X-ray mastoid basically has historical interest, but it's not commonly performed nowadays. If it is done, it shows clouding of ear cells, indistinct partitions in the ear cells because the partitions have been broken down, and irregular walled cavity because of collisions of the secretions. HRCT stands for high resolution contrast tomogram of temporal bone, which is the investigation of choice nowadays. We can see the disease extent, type of disease, as well as destruction by HRCT of temporal bone, and the course of facial nerve also can be seen when you do HRCT of temporal bone. Pus culture is to be done, which helps to select appropriate antibiotics when the person is not taking antibiotics previously. This is the X-ray mastoid, which is basically of historical interest. We can see the dural plate here. This is the dural plate, separates the dura from the mastoid. This is the temporomandibular joint and the sinus plate. So most important for us is to find out the temporomandibular joint at first in X-ray mastoid. This is important. Just if you see posteriorly, you can see a hollow air-filled cavity, that is the external canal. Okay, so in conjunction with the middle and the internal canal, and more posterior to this, you can see the mastoid cavity or the mastoid cell system. In this case, there are some pneumatizations over here. Its honeycomb appearance of the mastoid cell system can be seen. Let's discuss about abscesses in relation to mastoid. So there are subperiosteal mastoid abscess, which is the most common mastoid abscess. This is subperiosteal. Okay, it's a post-auricular abscess. Bijoul's abscess, which is in relation to sternocleidomastoid mastoid muscle. Secretary's abscess, which is in relation to the digastric muscle. Luke's abscess in the external canal. Then zygomatic abscess, which is present in the zygoma, anterior aspect, and the occipital abscess, which is more posteriorly. But some people describe occipital abscess as Luke's abscess, but for your level, MBBS level Luke's abscess is the abscess in the external aortic canal roof. So this has already been discussed here. This also has been discussed, and you can see the post-aortic fistula. This is the post-aortic fistula in case of CSOM aortic disease, and you can see mastoid abscess on CT scan. So CT scan is the one of the important diagnostic tool nowadays than X-ray of the skull. What is the treatment of acute Coalescent mastoiditis? So medical treatment has to be tried, which is the first line. Patient has to be admitted. Broad spectrum IV antibiotics are to be used, both to cover gram-positive, gram-negative as well as anaerobic infections. Anti-inflammatory agents to decrease the pain. And surgical treatment, when the medical treatment is not sufficed, then you can do surgical treatment. There are indications for surgery are when there is no response to medical treatment in 24 to 48 hours. The patient has to be better with use of medications by 24 to 48 hours. When there is poor response to 2 weeks of medical treatment, or any new complication or abscess formation occurs, because as you know, when the patient is having complications, there is chance of 1/3 complications might be there. So patient might have more than one complications together. Myringotomy, ING of the abscess or cortical mastoidectomy or can be performed when the patient is having acute Coalescent mastoiditis due to ASOM. But when the patient is having mastoiditis due to CSOM aortic disease, then mastoid exploration is to be performed. To differentiate acute mastoiditis from furuncle of the external aortic canal, there history of ASM is present in acute mastoiditis but is absent in furunculosis. Pena will be displaced forward and downwards in case of acute mastoiditis, but in case of furuncle it will be just simply forward. So discharge from the ear will be in acute mastoiditis will be mucoid discharge, but in furuncle it will be either purulent, thick purulent, or it might be absent. In sagging is present in case of acute mastoiditis, sagging is absent in case of furunculosis. But the external aortic canal might be edematous, might be swollen. TM congestion is present in acute mastoiditis, but there might be discharge, might be discharge or perforation. Furuncle, there is no perforation or no congestion of tympanic membrane because this is the disease of the external aortic canal only. So X-ray mastoid, it shows hedginess, coalescence of swells or irregular cavity in case of acute mastoiditis. But in furuncle, there will be a diploid or sclerotic mastoid. Pain in the pinna will be absent in acute mastoiditis but will be present in furunculosis. Lymphadenopathy will be present in furunculosis because it is usually to inflammatory swelling of lymph node in the post-auricular area. Then tenderness will be in the mastoidium, so called Simbaconchi will be tenderness. In case of acute mastoiditis, it will be tender. But in furunculosis, there will be diffuse tenderness. And that means there will be circumduction test will be positive. If you just hold the pinna and rotate it clockwise or anti-clockwise, patient feels severe pain. The next complication is acute petrositis, Gradenigo syndrome. It is defined as involvement of petrocytic air cells, which are named as in 20% cases only. So when the inflammation goes to petrocytic cells, so there might be petrositis, inflammation of petrocytic air cells. It is difficult to manage due to poor drainage system and proximity to neurovascular structures. So clinical features are Gradenigo syndrome. Gradenigo syndrome is defined as 3 triads. They are persistent ear discharge in spite of adequate cortical mastoid surgery, the retroauricular orbital pain due to 5th cannulum involvement, and medial squint due to abscess of paralysis or involvement. This is the abscess paralysis you can see here in the picture. This is the first is normal one. Okay. This is the normal. The child is seeing on both sides. It's almost. You see, you can see the lateral squint is there. So the child cannot see laterally, and in this case, the child sees towards both the sides. How to treat? Medically by IV antibiotics or anti-inflammatory agents. Surgical treatment without residual hearing when the patient is not having hearing at all. So you can do translabyrinthine surgery. So the hearing should not be there. So translabyrinthine surgery decreases patient's hearing. So posterior cells we can go through translabyrinthine approach and transcochlear route to anterior cells. When the patient has residual hearing, then we should not damage the labyrinth. So we have to go through retrolabyrinthine route, okay, or subarcuate route for the posterior cells and intracochlear routes for the anterior cells. This might come in the MCQs. Next comes labyrinthine fistula. It is erosion of dome of lateral semicircle is the most common Most common, dome of lateral semicircular canal. Usually asymptomatic, but symptomatic when there is large fistula that leads to episodic vertigo lasting for seconds to minutes, and fistula test will be positive when there is fistula. So in all patients of CSOM with vertigo, labyrinthine fistula must be presumed unless otherwise proven. So management is surgical treatment. There is no medical treatment for labyrinthine fistula. The cannula down mastoid surgery when there is large fistula more than 2 mm. When there are multiple fistulae or pulmonary fistula, and don't remove the matrix there. And cannula up mastoid surgery when the usually performed for small fistula less than 2 mm only, matrix can be removed. Facial paralysis, we'll discuss it in the subsequent class, but for the time being, in ASM it is due to congenital lesions, most common, and CSOM, cholecystioma, and erosion of the fallopian canal is the commonest one. Cholecystioma matrix sometimes may protect the facial nerve, sometimes. Investigations are HRCT again of temporal bone. Treatment is in ASM, you have to give IgB antibiotics, myringectomy, cortical mastoid surgery, or facial nerve exploration and decompression is usually not required because in ASM it is due to usually pressure effect. But in CSOM there has to be urgent facial nerve exploration and decompression because there is due to bone erosion or involvement of other structures. In case of cannula down mastoid surgery and exploration of the facial nerve from first to mastoid foramen is required. You have to see the level of the facial nerve injury. But if you do HRCT, then you can find out the site of injury. The repair of facial nerve, either rerouting into anastomosis or nerve grafting, can be performed. Coming to intra-cranial complications, just a short overview of intra-cranial complications. The features are high-grade fever, altered sensorium, irritability, generalized malaise, photophobia, neck stiffness, seizures or focal neurological deficit, and deep boring headache are the features of intra-cranial complications. Meningitis by far is the most common intracranial complication, and autogenic intracranial abscesses, extradural abscess, subdural abscess, and brain abscess are the common things. In brain abscess also it will be either temporal bone lobe abscess or cerebral abscess. Intracranial abscesses, 75% of brain abscesses are due to autogenic origin. CT MRI diagnostic, and treatment is by antibiotics, dexamethasone, which decreases the cerebral edema, and mannitol to decrease the CSF pressure. Patient has to undergo mastoid exploration for primary treatment, and abscess drainage or borehole or craniotomy can be performed. One of the important intracranial complication of CSOM is lateral sinus thrombophlebitis. We'll discuss this in details. So lateral sinus is defined as sigmoid sinus and transverse sinus is a combination of sigmoid and the transverse sinus, which is called as the lateral sinus. What is the fate of thrombus in lateral sinus? Thrombosis. So when the thrombus develops in the lateral sinus, there will be mural thrombus, which occludes the canal, which occludes the sinus later on, and that propagates. Okay, so leading to central breakdown and propagation. So at all the times there will be inflammation of outer dural wall. Mostly the inflammation occurs from here. So clinical features are long-standing discharging ear, hallucinatory discharge that suggesting of CSOM etiological disease. There will be high and stinging fever, so-called picket fans, with chills and rigors, which simulates malaria. There will be headache, otalgia, neck pain, and torticollis. There will be wasting illness because patient is being anemic, okay, and patient doesn't take properly. There will be impaired mental awareness, drowsiness, lethargy, and coma, and decreased vision with when there is raised ICT. Signs are: first is the patient will be anemic and wasted patients with history of discharge, which suggests of CSOM etiological disease. So discharge is foul smelling, okay, and sometimes blood stained. There will be tenderness at the mastoid process and neck along the sternocleidomastoid muscle, important, which is a universal finding. So in case of lateral sinus thrombosis, there will be pain or neck tenderness around the neck, around the sternocleidomastoid muscle. There will be signs of meningeal irritation seen in 50% of chance of other intracranial complications as already told. Papilledema can be seen in 50% of individuals, and Gradenigo signs is one of the common signs, which is pitting edema over the occipital region behind the mastoid process due to clotting within the large mastoid vein. So venous thrombosis again. Investigations are performed. Full blood count is performed to rule out anemia, raised WBC and raised ESR, blood culture to find out the organism, lumbar puncture if not contraindicated. When there is high CSF pressure, then lumbar puncture cannot be performed. Next is Clovic test, which is the compression of normal intrajugular vein. There will be engorgement of the retinal veins, which is in ophthalmos, because only the normal IJV release brings the blood from venous blood from brain to the heart. So the next is thrombosis. So it cannot flow. Okay. So if you compress the normal IJV, then there will be engorgement of retinal vessels. Tobey Ayer test is usually a historical test, again so-called Wittgenstein test, which on measuring the CSF pressure and observing its change and compression of one or both IJV on the neck. It is almost similar to Clovic test in the eyes. In normal subjects, when you compress each intrajugular vein, there will be rapid rise of CSF pressure above normal level, followed by rapid fall and release, normal difference in two sides being less than 50 mm of water. In case of lateral sinus thrombosis, if you press over the vein during the occluded sinus, there will be none or very slow rise of pressure will be there because there will be occlusion. But on compression of the normal IJV, this will be rapid pressure rise 2 to 3 times the normal pressure. Although false positive and false negative results are there, so it has low sensitivity and specificity. CT scan yet contrast can be performed, which shows increased density of fresh clot filling the defects within the sinuses. Our common sign seen in CT scan is empty delta sign with intense inflammatory enhancement of the sinus wall, adjacent dura, but not the contents of the sinus because they are clotted. So this is digital subtraction angiography or venography to see the site and extent of obstruction, and MRI to see the increased signal intensity in both T1 and T2 images and to see the venous flow. Radioisotope scan can be performed with gallium, which are spots of sepsis, blocked venous flow. This is the empty delta sign. You can see there is hyperintensity in the periphery followed by clot in the center. So there is no intensity seen in the center. How to treat lateral sinus thrombosis? High dose broad spectrum IV antibiotics are to be started when the patient comes to the emergency, and surgical treatment by complete mastectomy performed, sinus exposed, then abscess drained and the clot is removed. Because as known as an ENT emergency, and ENT surgeons can perform this surgery, so we have to perform as early as possible. Anticoagulants have no role except when there is cavernous sinus thrombosis. Intrajugular vein ligation also has not much role, but when there is septicemia which is not responding to antibiotics and surgery, or when the children show signs of embolization, then you can do intrajugular vein ligation. Otherwise, it's not required. Coming to next topic, otitic hydrocephalus, which occurs due to raised ICP due to failure of the arachnoid villi to absorb the CSF. So clinical features are headache, nausea, vomiting, blurring of vision. And lumbar punctures was high pressure but normal lab findings. Treatment is by acetazolamide, dexamethasone, and lumbar drain and lumbar peritoneal shunt if required. Last but not least topic for today is the brain fungus, which is defined as brain herniation in the middle ear or mastoid, usually after mastoid surgery due to defect in the dura. It is also rare nowadays. It was common in the past. It is common in pre-antibiotic era, but it is rare nowadays. Diagnosis by CT scan of head and temporal bone. You have to see the brain tissue in the mastoid cavity. Treatment is by cautery and removal of the prolapsed brain and repair of the defect are to be performed. Thank you so much. Subscribe my channel and like and share for other videos. Thank you so much, and just give me comments, give me feedbacks. How is the session like? Okay, thank you.